So, welcome to week 19 of our neuropsychiatry didactic series. This one is going to be on personality disorders. I do want to announce a pretty big disclaimer that this lecture is especially hand wavy, and these personality structures are probably more clear when there's like a defined lesion and personality change, while personality, if you're a psychoanalyst or a very, astute psychiatrist who might be a little disappointed in the lack of depth in this talk, I think it's important to see personality disorders as a more of a neurodevelopmental sequelae related to our attachment and upbringing, rather than specific discrete, brain structures and circuits. But those structures and circuits are still, how we make ourselves. It's just harder to find and harder to talk about. So that's just an inherent limit of this subject matter. These are our learning objectives. You can see that if you like. And as always, we'll start with some history. So personality pathology over history has this theme of starting to be seen as a moral failure, and maybe like a more of a defective sense of character. And then over time, it was seen as more of an ego pathology, and now we see it as a more of a neurodevelopmental network dysfunction of certain self-regulatory circuits. And so, history kind of shows this by initially with Philippe Pinel, I believe his name is. He described in French manie sans délire, which described people as having madness without delirium. And so they behaved destructively, but their reasoning seemed to be preserved. And that seemed to be one of the earliest ideas of seeing, pathology of personality. Then, of course, Emil Kraepelin always comes in, and he described these people as having psychopathic personalities. Um, and then Kurt Schneider in 1923 formalized, these psychopathic personalities, and defined these disorders as a sort of abnormal personality that caused suffering to themselves or others. And then psychoanalysts came in the mix, and further conceptualized these personality structures in terms of organizations, in really great depth that we will not be able to cover here. But really good stuff. If you want to get into it, you could probably dedicate your whole life to it. And there's certain concepts that were relevant, like ego strength and defense mechanisms, and how one interacts with the world through an object relations lens. There's a very famous battle between Kernberg and Kohut on different notions of narcissism and why narcissism arises. And then by the era of the DSM, from 1 through 5, every etiology was kind of thrown out the window with a different way of conceptualizing this, replacing it. And then eventually by the DSM-5, these were sort of categorized in different clusters based on their common traits that we'll talk about here. And then in the current day, there's still a lot of different perspectives. One of my favorite ones is Nancy McWilliams, and based on her psychodynamic work on personality structure, she has a book on personality that's really helpful. And I was trying to see if I had it so I could show it, but there's the book on the bottom right here, the psychodynamic diagnostic manual, is also based on her work. Um, and let's see. But then, yeah, there's also all kinds of modern cognitive neuroscientific ways of seeing this as well, including seeing these disorders, in terms of affect regulation, self-other representation, along with other, more obscure moral and social cognitive ways of seeing personality, which we'll discuss on this talk. And then, of course, personality is deeply ingrained in somebody's own cultural context. And it's important to always think about this in terms of how one's personality is shaped by early attachment styles and development, which is a lecture in itself, and their own moral narratives. Um, and in terms of attachment styles, it's helpful to think that people who have secure attachment styles tend to have a more robust connection between their orbitofrontal cortex and their limbic areas, which would lead to a more stable and reassuring predictive coding from a computational psychiatry standpoint. And so the reason that it's important to note that is that that tends to also be protective from developing other psychiatric issues going forward, as opposed to other attachment styles. And so personality is deeply ingrained in one's own, psychiatric structure as well. So to talk about, specific, I guess, differences in culture, there's definitely a contrast to be made between individualistic cultures versus more collectivistic cultures. So, individualistic cultures are usually, more like Western Europe and the US. These people tend to value autonomy, assertiveness, and self-expression, prioritize those things. And they may pathologize dependency and perceived emotional weakness. This is really important because personality disorders are sort of shaped by what is seen as normal by the society, by that's diagnosing them, and what they tend to pathologize are usually, it's kind of controversial, but maybe traits that aren't, um, uh, you know, uh, as welcomed in the societies, um, and that's usually that could be at the expense of overlooking aspects of their societies that might be, not that great, but are valued. And so, in individualistic cultures, it's kind of interesting to mention that, narcissistic and antisocial traits may be, more valued and subtly even reinforced before actually becoming maladaptive. While collectivist cultures, are very different in terms of their values. They might value more harmony and interdependence, and their own relational obligations. And so, in these cultures, dependent and avoidant traits may be adaptive, and also, sort of hidden, while narcissistic and antisocial traits would be more likely to be stigmatized. And so in the bottom right here, we also see this little caveat from the DSM-5, which gives us a reminder to interpret a patient from the context of their own cultural upbringing and attain further information, from collateral if needed, so we can try to avoid over pathologizing somebody just because they might be from a different cultural perspective than our own. Okay, so how do we define personality? Well, it's hard. It's really defined as an enduring organization of emotion, cognitive, and interpersonal patterns that shape an individual. And so this relates to, how we think about ourselves and others. The DSM-5 specifically defines personality disorders, as we see here on the bottom, as an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. So these patterns are inflexible, pervasive, and lead to a clinically significant distress or impairment in social, occupational, and other areas of functioning. It's important to note that these patterns are egocentric, so they're not readily in conflict with one's identity or distressing to themselves. Um, and so they're recognizable pretty early in development, even as early as early, and it could be in early adulthood, at the latest, really. Ideally, a true personality disorder is something that is part of your personality, which has always sort of been with you. So, it's not like other primary psychiatric conditions that just pop up, in your late teenage to early 20s. So let's go a little deeper into the DSM-5 and how they see personality disorders. The DSM-5 is going to be what we're going to use to describe personality disorders. There's way more nuanced ways to see this, so just got to keep in mind here. So the most common and agreed on classifications of personality disorders at this time are as follows here. The DSM-5 is, as always, agnostic towards etiology, and this is more, just a classification system for diagnostics and billing. And it's also helpful just to facilitate a common language between clinicians. Um, Although, as we'll see here, it doesn't actually always align as well with neurobiology. And doesn't really map as cleanly onto brain circuits as everything else that we talked about in other lectures so far. And so the personality disorders are based on different clusters. And so there's three clusters here. Cluster A is overall defined as being relatively odd and eccentric. These people, can be at least the personality disorders included here are paranoid, schizoid, and schizotypal personality disorders. Cluster B, these people are usually defined by being relatively dramatic and emotionally labile. And this diagnoses here can include antisocial, borderline histrionic, and narcissistic personality disorder. And then cluster C is defined by being anxious and fearful. And diagnoses here include avoidance, dependent, and obsessive compulsive personality disorder. Um, and so there's like other ways to see this too. One is you can group them as I believe it's weird, wild, and wacky. Is one way that people remember this. Although I don't really know how to tell the difference between wild versus wacky. And then another way is that people don't have to really make the diagnosis. They can also just have traits of each diagnosis. And so it's very common that you'll hear that, some people have, either borderline traits specifically, or they can just have cluster B traits overall. And that's a common thing that we talk about. So to talk about cluster A, a little more in depth. So cluster A is defined by social detachment, really, and they might also have associated cognitive or perceptual distortions. These people tend to live between a normal variation of personality and more of a schizophrenia type spectrum. Of course, they don't have schizophrenia, but just conceptually, they're kind of between, what we would normally expect from somebody's personality to almost like a psychotic disorder. And so you can read each of the DSM-5 criteria specifically here if you like, but just to keep it brief, starting up top, paranoid personality disorder. This is defined by a pervasive distrust in others and a heightened threat detection. These people seem like they're jumpy and always on edge. In the middle here, we have schizoid personalities, which are defined by their detachment from relationships and having restricted affect. These people often tend to be loners. But they're also, pretty happy with that. Like they don't really have desire for relationships, so that's fine. And then at the bottom here, we have schizotypal personality disorders, who are people who are defined by having odd beliefs and magical thinking. These people tend to be seen as eccentric and unapologetically just out there. It's a little different than schizoid in that these people do want to have relationships just like anybody else in the world. And like schizoid, they actually might be a little more socially isolated, but it's not because they want to. The difference here is that, maybe their ways are just a little jarring for people, and that unfortunately keeps them from making close relationships. And then for the cluster B, this is probably the most common here. But again, we're going to keep this short. Starting with maybe the most common is the top left here, borderline personality disorder. These people are defined by having emotional instability, feelings of emptiness, impulsivity, fears of abandonment, unstable interpersonal relationships, and even recurrent self-harm. These patients, commonly have a lot of psychiatric admissions for recurring suicidal ideation and self-harm. And then on the top right, we have what's probably just as common, maybe a narcissistic personality disorder. And psychodynamically, these people share a lot of developmental overlap with borderline personality disorder, but they just manifest very differently. And these people are defined by having a lack of empathy, external grandiosity, and while also having an internal fragile self-esteem with need for admiration. Um, these people, tend to actually be found very commonly in high positions of power, being, of course, leaders of the free world, head of large corporations and hedge funds and whatnot. Bottom left here, antisocial personality disorder. These are defined by having impaired empathy and disregard for the rights of others. They're commonly diagnosed actually with a different diagnosis when they're young. So before the age of 15, they commonly have conduct disorder if they've been seen by mental health professionals. And these patients are commonly found in forensic settings in the prison system. And then at the bottom right, we have histrionic personality disorder, which are people that are defined by their attention-seeking behavior and having, excessive emotional expression, and really like to be seen and kind of flaunt their looks and things. So these people tend to be in sort of like front of stage jobs, like acting, modeling, or fashion. All right. So cluster C, these people are defined by just having chronic sort of anxious behaviors and rigid behavior inhibition. Maybe psychodynamically they're seen as more neurotic. And these people tend to be overly cautious and risk averse, and desiring predictability. Um, and so each of these personality disorders here, let's start from like the top left here with avoidant personality disorders. These people are defined as being hypersensitive to perceived social criticism, and so or rejection, and so this leads to a lot of avoidance behaviors. These people, may be perceived as loners. They do to and this is usually due to avoiding social interactions. And to contrast this with schizoid, these people do desire social connection, but they're just afraid of it. This is like an extreme form of shyness. Um, and then in the middle, dependent personality disorder, these people are defined by having excessive need to be taken care of and difficulty making decisions independently. These people tend to lack a sense of self overall, but in contrast this to that lack of sense of self, that we can see in like borderline and narcissistic patients, these people tend to externalize their fragile autonomy and externalize their self-regulation onto somebody else. Obsessive compulsive disorder personality. Obsessive compulsive personality disorder. These people are defined by traits of perfectionism, rigidity, and control. I'm sure we all have patients who have, and I'm sure we all have friends, honestly, that have some level of this. And these people tend to have excessive devotion to work and productivity, which tends to work in their favor, which is in contrast to OCD, which is what's called ego dystonic, meaning that it's not in their favor. OCPD tends to be more egocentric. And just to actually go to this real quick, another way that we can see these personality disorders overall in a very broad scope, psychodynamic way, is that Freud talked about kind of like where the ego is in relation to the id and the superego. And so if the ego is absorbed by the id and people are a little more on the psychotic, id spectrum, that's more in the cluster A. Um, remembering that the id is really, the wants and desires of the libido, and this is more correlated with like limbic circuits. While if somebody is more leaning towards the needs of society and really trying to fit, this rigid view of how they should be, that's more of a super ego leaning ego, and that would be more cluster C, while cluster B people tend to be sort of in the borderlines between psychosis and neurosis, and so they're right in the middle, and that's actually how borderline got its name. All right. So now we're going to talk about some of the functional neuroanatomy because this lecture is a little hard to really pin down. I'm actually going to talk about it in terms of different things that may or may not relate to each other, and hopefully they do relate to each other. So starting with affective systems. So our affective systems is based on affective neuroscience by Jack Panksepp, and these are limbic circuits that generate emotional salience. Then we have regulatory systems, and so this is like the prefrontal and orbital frontal cortex, and they're related. Their main role is to moderate impulse control and emotional control as well. Then we have these self-referential systems, which are mostly the medial prefrontal cortex and the default mode network, and they maintain the continuity of identity. While social cognition systems which is the temporoparietal junction for the most part, holds representations of self and others in relationships. So we'll discuss here some of the recurring nodes within these systems, and yeah, this is there's actually a lot to talk about with all of these, so I'm sorry ahead of time if it's too much. But starting with the orbital frontal cortex, this normally works in value-based decision making, emotional regulation, and updating behavior based on rewards and punishment. So, it's very shaped by society and sort of that super ego structure. And when this is impaired, patients can present as being impulsive, labile, along with having inconsistent social and moral reasoning. In neurology, when there's like a TBI that affects the OFC, this commonly presents with disinhibited behavior. But in psychiatry, it's a little more, subtle, but it can get pretty obvious. And the extreme sense here is in antisocial personality disorders, where people, like have like deficient moral learning and evaluation of consequences, or in borderline personality disorder where emotional regulation is deficit. And second here, temporoparietal junction. Normally, this works in perspective taking and theory of mind, along with empathy and detecting agency. When this is impaired, boundaries between self and other may blur. There's other intentions that may be misread, and empathy, which may become inconsistent or absent. And as we'll learn in our future neurology lectures, this area is actually important in functional imaging studies in conversion disorder or FND or functional neurologic disorder. Um, while in psychiatry, we see this as being functionally, an issue with narcissistic personality disorder, where empathy is more deficient, or borderline, where the boundary of self is blurred at times. There's also something to be said about mirror neurons here, but I think that's beyond the scope of this lecture. Third here, we have the medial prefrontal cortex. This is the primary node of the default mode network. It regulates self-referential thought, autobiographical memory, and the continuity of identity through time. And the stable sense of self is definitely dysregulated in a lot of cluster B disorders. Definitely unstable in borderline, and it could be excessive and grandiose in narcissistic personality disorder. The insula, of course, normally it provides awareness of bodily sensations, that emotional feeling or subjective states of feeling, along with integrating somatic and emotional signals into something that's salient and felt. And as we've discussed before in our anxiety lecture, when this is heightened, there's more of a feeling of a somatically driven anxiety. And we can think of this as also being heightened in our cluster C personality disorders that are, that tend to be more hypervigilant and anxious. And finally, the amygdala, as we've discussed before, also in our anxiety lecture, this revolves around salience and threat detection. It's typically triggered pretty rapidly to any emotion of like immediate fear, and this could generalize, as we talked about in our last lecture as well. It could generalize into the BNST and cause this like an anticipatory anxiety involving the extended amygdala. And so this is commonly implicated in the daily experience of people who have like paranoid personality disorder, who have a particular sensitivity to threat and are kind of always on edge. So let's go a little more specific into each of these, starting with the orbitofrontal cortex, and we're going to go one by one. The orbital frontal cortex is kind of like a neuroanatomical superego of sort, mostly because it integrates the rules and values that we use to encode social norms and modulate our impulses. And then it's also involved in possibly generating guilt and remorse through the consequence, through learning, the consequences of our actions. And then the OFC, this area, the classic story of somebody who had their OFC broken with a rod is the guy here in the bottom right, which is Phineas Gage. He famously had got a rod stuck through his frontal lobes, and this led to a disinhibited personality change for the rest of his life. Um, as you can imagine, we see this part of the brain affected pretty commonly with frontal brain injuries, and this, as we've said before, leads to disinhibition, but also emotional lability, poor judgment, and just difficulty learning from negative consequences, which can be pretty frustrating. But if we understand that, this awareness is coming from the brain, hopefully it can also give us some empathy too. Ironically, issues with this area of the brain can lead to lack of empathy. And sometimes people who have had this damaged, this type of TBI has previously been called as an acquired sociopathy or a frontal personality syndrome. And so, one thought here is that there might be poor functional connectivity of limbic areas to the OFC, especially in cluster B patients. But we still need more research, really, to be sure. On the second area here, we're going to talk about the temporoparietal junction or TPJ. The TPJ is really essential for mentalization, which is our capacity to understand that other people have minds too and try to understand their intentions and perspectives as distinct from our own while also having empathy. And as you can imagine, this area is really essential for kind of integrating empathy, social perception, along with our own agency to things. And so the TPJ is located right between the temporal and parietal lobe, hence the name. And basically, the idea here is that social perceptions and memory are drawn from the temporal lobe, while spatial attention and body schemas are drawn from the parietal lobe and integrated in this junction. And as you can imagine, if this isn't really working well, there might be, some misunderstanding over other people's intentions, so people may be perceived as hostile, rejecting, or manipulative. There might be some difficulty distinguishing between internal feelings and external reality, along with some deficient empathy, as we mentioned. This can even lead to delusional misinterpretations of people's beliefs, and how people, the beliefs that people may have of us. And this may functionally be seen in a lot of personality disorders that are defined by deficits in social cognition, such as cluster A personality disorders, which may include like suspiciousness, which is a paranoid trait, social withdrawal, like in schizoid patients, and perceptual distortions like we see in schizotypal patients. But other conditions can also affect this area, especially neurological things that we see pretty often, like Alzheimer's, but also autism and schizophrenia. And interestingly, all three of these are have been, had some history shared. Obviously, Alzheimer's disease is a dementia. But schizophrenia used to be known as dementia precox. And Bleuler used to define schizophrenia by these four A's. And one of the A's were autism. And so, autism, schizophrenia, and Alzheimer's disease tend to have some kind of phenotype that this phenotypic overlap. And it maybe one of the things is this deficit in theory of mind because of the involvement, whether it's structural or functional, of the temporoparietal junction. And so in neurology, I think something that's even more dramatic than this is sometimes we can see right-sided strokes, which could affect this area and cause, if it's on the right side, it will cause a hemi-neglect, neglecting the left side of the world. And experimentally, there have been like if you kind of shock this area temporarily, it's also been implicated in out-of-body experiences. So let's see. So putting all these nodes together so far, we can kind of think of them generally working together in different circuits. And so, one circuit here is that the amygdala, of course, works really fast and can pick up on some salient stimuli. The insula then registers this into a subjective feeling state, as we kind of covered with our anxiety lecture. The orbital frontal cortex does what it does, which it, regulates and contextualizes that emotion. And the medial prefrontal cortex will then integrate that emotion into one's identity, and the temporal parietal junction will contextualize that emotion in relation to other people. And so, developmentally, it's also important to know that these systems mature at different rates of development. And so the limbic system matures actually pretty early, but the prefrontal cortex matures pretty late. And the temporal junction, really develops depending heavily on social learning. And so, that's really, really important for us to keep in mind because, babies are all limbic and no frontal lobe. And so you have this, very labile, intense affect that comes out very, very early on, just right when they're born. And then it's not until after high school that our frontal lobes are done regulating. And in the meantime, we're just picking up on social cues and trying to learn and adapt accordingly. And so at any time through this, whether it's because of early trauma or neglect, we can have a dysregulated attachment style can really mess up our social development and eventually lead to a maladaptive self-organization. And we usually meet people after they've developed at least people who have personality pathology after all of this has kind of been done. And they've been shaped by their own social context and environment. And that's usually what's leading to this maladaptive self, which we call personality pathology. So of course this is like, super simplified. And this circuit is more of a heuristic rather than an actual like super scientifically backed understanding of personality formation, which I'm sure is way more complicated than this. But here's just a review of all the personality disorders that we discussed so far, their features, and how they may relate in a very hand-wavy way to these different nodes of the brain. You can go through that on your own time as we discuss some clinical relevance here. So evaluating personality disorders, honestly, is usually not really done in an inpatient setting. And it usually doesn't really overlap with a lot of me other medical stuff. But it can definitely get in the way of medical treatment, and definitely plays a frontline role in how we interact with our patients as well. And so and very rarely, it could get misdiagnosed with other with neurologic conditions, but maybe more commonly it gets misdiagnosed with other psychiatric conditions. And so for good and bad, we always have to do a psychiatric history, whether we're testing for this or not. And you might need to call collateral, which would help establish more of a better time frame. There's more structured tools out there. Although, these are listed here like the SCID-5, PD, IPDE, and PID-5. This is more, done in research settings. More commonly, we'll just use, have like a heuristic of DSM-5 criteria, along with a good longitudinal history, which would be more the gold standard of evaluating this. Neuropsychological testing is done more only if, like, there is a dramatic change in baseline, and this happened, this was more of an acquired thing, such as the case with like frontal TBIs, behavioral variant of FTD, brain tumors, autoimmune encephalitis, epilepsy, maybe substance use, and then. And you should also keep in mind to try to rule this out. The main thing to take away from this slide, if at all else, is just to establish timing. If they've been like this their whole lives, then it's likely related to some kind of personality pathology. And if this is an acute change, then now we're thinking more on the neurological side. And so only if there's an acute change and we're thinking neurological would we actually consider neuroimaging for any reason. But that's very case dependent. All right. So in terms of meds, I'm only adding this because I talk about meds with every presentation, but there's really no medication that's approved for personality disorders. It just doesn't make sense to use one since this is more of a stable brain state, that isn't really targeted by any specific meds, at least as of now. But the mainstay of treatment would be psychotherapy. There is some very, like groundbreaking, under investigation, ways to use maybe psychedelic assisted psychotherapy for personality disorders. But of course, there's definitely a lot of need for a lot more research, and it's too early to really use this at this time. But there's certain comorbidities and symptoms that can be targeted with psychopharm, and psychopharm is probably better indicated when it's a neurological change in personality. So if somebody with TBI who's like impulsive and labile, SSRIs could be helpful. SSRIs could also be helpful in people with dementia who have like similar brain circuits that are disrupted. If they're almost like, if they need a mood stabilizer, we can use that for like affective storms and aggression. It's very common that we use Depakote for aggressive people with, like, let's say, antisocial personality disorder who are, have been dangerous in the past. Um, and then atypical antipsychotics, shouldn't really be used, to be honest with you. But if they have very, like disabling paranoia, and they need something to temporize them while they're going through therapy, then this could be considered. And then, for the longest time, I just added here, just because it's very commonly done. You might see somebody with like borderline who's like on like 5 milligrams of Abilify or something like that, and psychiatrists for whatever reason call this ego glue. But I don't think that there's much research on this, but I could be wrong. And then psychotherapy, like I said on the previous slide, this is really the mainstay and should be first line for any personality disorder. And to fully review this, it would really be a lecture in itself. So we're really just taking broad strokes here. And I really want it to be relevant to this presentation. So I'm talking about these therapies specifically in terms of controlling the circuits that we've discussed so far. And usually it's going to be a combination of therapies too. Even though like the textbook answer, if you hear borderline, you should do DBT. In clinical practice, it's really not that simple, and it's really not as effective as at least maybe I would hope it would be. Um, and so, so let's talk about them each and then how we can combine them. So DBT is dialectical behavioral therapy. This is most commonly recommended for BPD, like we said, but it can also, be helpful for any cluster B traits. And this therapy really provides like skills trainings, and it builds a sort of cortical scaffolding for emotional regulation. Um, MBT is mentalization-based therapy. And this addresses failures of mentalization under situations of being under emotional stress. It lets patients learn to reflect on thoughts and feelings rather than act out on them. And it focuses on identity across relationships. And as you can imagine, this is especially useful for whenever you think that this patient has like a temporoparietal junction, mediated deficit of some kind, as we discussed before. Schema therapy is pretty interesting. It focuses on more rigid emotional cognitive patterns that were formed in early development, and it introduces a corrective emotional experience with the goal of weakening those old pathways and strengthening an alternate regulatory circuit. And then TFP, which is transference focused psychotherapy. This is sort of a grandchild of psychodynamic therapy, and it addresses identity diffusion, splitting. It's commonly seen and used in cluster B pathology, and it uses the therapeutic relationship itself as a structure to activate dominant emotional states, interpret those in real time, and gain insight into oneself, and it can be really, really helpful. So there's way more therapies here, and maybe we'll slowly cover them in future lectures, but we definitely don't have time to cover it in this one. So for borderline traits here, I added what could be some of the most helpful therapies and the primary neurotarget as well, which would be more like the orbital frontal emotional regulation aspect, along with theory of mind in our sense of self with the TPJ. Narcissistic traits is also targeting more TPJ and medial prefrontal cortex for regulation. Uh, for antisocial traits, you're thinking more like enhancing their superego through orbital frontal cortex moral learning, and this would require more long-term therapy. It's very, very, very difficult to treat. Avoidant traits, you're really trying to stabilize fear circuits by empowering more medial prefrontal cortex and improving insight. So that's more psychodynamic stuff. But also cognitive behavioral therapy will, add to more executive control over these lower brain centers, including empowering the dorsolateral prefrontal cortex to regulate the insula and especially provide insight to any anxiety or somatic states. And then OCPD is interesting because now this is the only one that you're just very hyper frontal, if anything, and rigid and hard and there's you lack cognitive flexibility. So you want to add more creative like psychodynamic aspects, possible schema therapy to rework those maladaptive patterns to enforce some plasticity between the OFC and the default mode network. All right. And so finally, to close off, we're going to talk about personality from a neurological standpoint, which is also a lecture in itself. And most of these bullet points are actually lectures that we'll have in the future. But I think I definitely don't want us to, overdiagnose people, but these are just, helpful heuristics to keep in the back of our mind. Starting from the top, which is the most dramatic one, which is a frontal lobe syndrome. Um, And these can mimic personality disorders with new emotional ability and disinhibition. This could, of course, be seen in TBIs, especially affecting orbital frontal cortex, and it can lead to impulsivity and poor insight, or that acquired sociopathy that we talked about. There's also BVFTD, behavior variant frontotemporal dementia. This is defined by personality changes that resemble frontal TBIs, but it's more commonly involved in with a loss of empathy and emotional blunting. And these symptoms can actually precede any memory deficits at all, despite being called a dementia. And so people can be, can kind of resemble a sort of antisocial or narcissistic personality disorder. And then temporal lobe epilepsy is kind of interesting. We're going to talk about this a little bit with the epilepsy lecture. But there's something that's been called the interictal personality. Um, and this could at times resemble a cluster A personality disorder with paranoia and possible hyper-religiosity. And while others are more anxiously driven, and that could look more like a cluster C personality, like with anxiety and interpersonal sensitivity. That's interesting to think about. But yeah, so that is basically personality from a neuro and a psychiatric standpoint. These are my references. And as always, there's questions on this slide if you want to check them out. And yeah, thanks very much.